This video demonstrates the technique of hepatectomy for secondary deposits from a Wilms tumor. The child was a 7-year-old patient who had undergone a left nephrectomy a year previously, and metastases developed in the left lobe of the liver adjacent to the falciform ligament. The procedure was performed through the standard subcostal chevron incision, and 1:400,000 lignocaine with adrenaline was infiltrated into the subcutaneous tissue to minimize oozing. This child has been on chemotherapy for about the past year, and the metastases have appeared in the liver in spite of that, which goes to show that the tumor was probably chemo-resistant when it was taken out. Another thing to note when operating on children with malignancies, especially those who have undergone chemotherapy, is that they tend to have a little more oozing than normal patients. So it is important, especially when making large incisions as this one, to be very careful about hemostasis right from the word go. So after dividing the skin and the subcutaneous tissue in the line of incision, we are now cutting through the muscles of the abdominal wall and have reached the peritoneum in the central part of the wound, which gives us access to the right subcostal area. As expected, because of a previous major surgery, there is a degree of intraperitoneal adhesions, so it is better to make the other half of the incision for adequate exposure. One of the important principles of liver surgery is not to struggle for access. Therefore, after assessing the situation, we are extending the right hand side of the incision a little bit. After gaining adequate exposure, the next step is to mobilize the liver completely from all sides, which means division of the right and left triangular ligament. And it seems as though the access is a little limited, necessitating a further extension of the right hand incision. We are now proceeding to divide the right triangular ligament and the regions which anchor the liver to the diaphragm. Getting a clear plane between the liver and the inferior vena cava for subsequent control of the hepatic vein. One may wonder why we are doing this on the right side when the procedure to be performed is a left hepatectomy, but as you'll see a little later, the situation of the metastasis is very close to the falciform ligament and the left hepatic vein. And there you can see the metastasis just under the index finger of the assistant, and this is just the tip of the iceberg. There was a large metastatic mass in the left lobe which was almost impinging on the left hepatic vein. So we anticipated that it would be difficult to get control if we mobilized only the left side of the liver, and hence adequate mobilization of the right side and exposure of the vena cava on the right side was also done for the sake of operative safety. We are now separating and dividing the two layers of the falciform ligament as they reflect onto the liver, and this is also an aid to getting good exposure of the retrohepatic vena cava and the area of the hepatic veins. It does not need to be stressed that hepatic vein control is perhaps the most important aspect of a proper hepatectomy, and if this is achieved adequately, a lot of the problems get resolved. So all the steps necessary should be taken to ensure that the hepatic veins can be safely and adequately controlled. So proceeding now with the clearing and division of the left leaf of the falciform ligament, and this is very near the site of the metastatic mass, which you can see lying just underneath it. This is the exposure and division of the left triangular ligament, continuing onwards where it merges with the diaphragm and the left side of the retrohepatic vena cava. You can see the diaphragm being tented by attachment to this strong ligament. Once it is divided, the left lobe becomes relatively free, and we can now see the metastases clearly. They are situated in the posterior superior part of the medial side of the left lobe, adjacent to the falciform ligament, and the actual metastatic mass is about 4 times the size what is visible on the surface. Proceeding now to the underside of the liver for inflow control, we are trying to expose the structures in the hepatic fissure. This is where we gain control of the inflow to the left lobe, namely the left branch of the hepatic artery, the left branch of the portal vein, and the left hepatic duct. We are beginning the dissection at the porta hepatis near the neck of the gallbladder. This, being the most easily recognizable landmark, will act as a guide to the other structures. By gradual dissection, we have removed the front layer of peritoneum covering the structures at the porta hepatis, and we know that starting from anterior to posterior, the duct, artery, and vein lie in that order. The structures also have to be isolated in the hepatic fissure because sometimes that is where the portal vein divides into the branch which is going to the affected lobe. We have partially isolated the left hepatic artery there, and a piece of gauze is being placed under it to control a bit of oozing that is happening from behind it. And you can see that a rubber sling is now being passed around the left branch of the hepatic artery and will be held up so that the dissection of the other structures is facilitated. So there's a bit of further oozing from the porta hepatis in the region of the gallbladder neck. It's probably a small micro vessel which is easily controlled by coagulation. So as we can see, the structures are usually pretty firmly bound down at the porta hepatis, and patient dissection, gradually separating them, is the only way to go about it. You can see the duodenum being retracted downwards by my assistant hand while he holds up the left lobe of the liver to put the structures at the porta hepatis on a mild degree of stretch. And you can then separate the various bits of fibrous tissue until the vein, artery and duct are clearly outlined. We can now clearly see the common hepatic duct with the cystic duct joining slightly lower down. The hepatic artery is already in its sling, and just behind the center of the porta hepatis is the portal vein, which we are going to expose and put rubber slings around all the three structures. So you can see that the yellow sling is now around the left hepatic duct and the blue sling is around the left branch of the portal vein. We have moved over to dissection of the liver from the underlying vena cava in order to provide a little bit of clearance on the right side as well, so as to be able to control the left hepatic vein effectively when the hepatotomy is performed. The retrohepatic vena cava has several small venules which connect the caudate lobe to the vena cava. Each of these has to be carefully isolated and double secured before division because they can lead to very troublesome bleeding, being direct tributaries of the vena cava. Having completed the dissection on the right side up to the level where the vena cava disappears behind the diaphragm, we are now shifting attention to the left side to approach the left hepatic vein. There is a tough phreno-liver ligament which has to be carefully separated. It will become clear here why the right side of the vena cava was also mobilized off of the liver, as it is very important to have both sides clearly visible at the site of the hepatic veins to prevent inadvertent injury which is very difficult to control. The tissue between the left side of the caudate lobe and the lesser curvature of the stomach is now being dissected, as this will provide further visibility and access to the area of the left hepatic vein. We are just tying off one of the branches of the left gastric artery in the lesser omentum. We have now shifted the dissection to the underside of the liver again, and this time it is in the hepatic fissure. There is a bridge of liver tissue, as can be seen, which is bridging over the contents of the hepatic fissure, and this has to be dissected off and divided before we can approach the portal vein, artery and duct in the hepatic fissure. Here we can clearly see that the three structures have been held up in rubber slings, and we are just trying to continue the dissection a little further so that the inflow to the left lobe is completely isolated before we perform the hepatotomy. The little bridge of liver tissue which is going across the hepatic fissure will have to be dissected off and divided to approach the contents under vision. Here we are dividing the part of the liver capsule which goes across the contents of the hepatic fissure, and you can see that the continuation of the right hepatic and the left hepatic artery is gradually coming into view as it is held up in the orange rubber sling. Little by little, the overlying fibrous tissue and the peritoneum is being divided in the hepatic fissure to further clarify the three structures which traverse it. We can see the continuation of the left hepatic artery, and a little later we'll also see the left branch of the portal vein and the left common duct. So, having exposed a sufficient length of the left hepatic artery, we are now in a position to secure it and divide it, and this will reduce the inflow to the left lobe of the liver while leaving the hepatic vein open to decrease the vascularity and bleeding during the hepatotomy. So that's the hepatic artery being carefully divided, and it will now be ligated. Here we are also tying off some of the tissue adjacent to the just divided left hepatic artery, as it may contain a few unmanned blood vessels, and it is better to secure it rather than divide it and then face troublesome oozing. With the division and ligation of the left hepatic artery, we can see that the color of the affected part of the left lobe has changed appreciably to a much darker brown, and we are now proceeding again into the region of the left hepatic vein to try and obtain control before performing the hepatotomy. The junction of the diaphragm with the liver is clearly visible. However, the hepatic veins are hidden under a very tough fibrous tissue ligament, which has to be carefully dissected before they become visible and can be clamped. Here you can see the top part of the tough phrenohepatic ligament, which covers the three hepatic veins and anchors the liver to the diaphragm. This lies within the two leaves of the falciform ligament just behind the bare area of the liver, and it's only when this ligamentous tissue is teased apart that we can get access to the hepatic veins. As we know, the three hepatic veins lie quite close together, the total width of the area being just about 2 or 2.5 centimeters, and you can just see between the jaws of the artery forceps the bluish sheen of the left hepatic vein under the fibrous tissue. The metastatic mass extends from just near the hepatic fissure well into the left part of the lobe and is actually about 4 to 5 times greater inside the liver than is visible in these three small nodules on the surface. So we can see the hepatic vein coming into view there just under the right angle dissecting forceps. The left hepatic vein is forming the edge of the three hepatic veins on the left side. We are continuing the dissection again on the left hepatic vein from the underside of the liver, progressively dividing the fibrous tissue. This is the left branch of the portal vein being secured before it is divided, after it has been isolated in the hepatic fissure. You can clearly see the right branch going towards the right side. So that is the left branch of the portal vein being divided after being doubly ligated on both sides. As we all know, the portal vein is not a vessel with which you take any sort of chances. Even after all this security, there is a bit of a leak from the liver side which is clipped away. Naturally, we want to make absolutely sure that there is no sort of bleeding from the stump of the portal vein after the hepatotomy has been performed. Another thing which would have perhaps been observed in the course of this operation is that hand knotting is always more comfortable compared to instrumental knotting. Even with modern sutures like silk and vicryl, a less than appropriate needle holder or artery forceps may actually fray or break the suture at a critical point. Therefore, where critical security is required, hand knotting is always the best option. So having isolated all the inflow, we are now marking out the line of resection for the hepatotomy, giving a clear 1.5 centimeter margin from the medial border of the metastasis. and the line is being marked both on the dorsal and the ventral surface of the liver, following the line of the hepatic fissure, which marks the anatomical boundary. Before starting the hepatotomy, we are putting a sling to occlude all the inflow from the liver, and this is passed through the foramen of Winslow and is actually a size 8 feeding tube, which will be gently tightened and held in an artery forceps till the hepatotomy is complete and we have secured hemostasis. So the hepatotomy is being performed with a combination of coagulating diathermy and fracture by an artery forceps. We know that there are several methods of doing this, finger fracture of the liver parenchyma being one of the preferred ones. Using an artery forceps provides a little more accuracy and still preserves the elastic vessels and ducts, which are individually clipped. So, proceeding alternately on the dorsal and ventral surfaces of the liver, we are progressively increasing the hepatotomy, and you can see the effect of occluding the hepatic inflow, that there is relatively little bleeding at this stage. As the larger vessels and ducts come into view in the depth of the hepatotomy, they are individually secured and divided, and the fracture of the liver parenchyma continues. We are now approaching the area of the hepatic vein, which is the final part of the hepatotomy to be tackled. So this is another major vessel in the depths of the hepatotomy, which has to be individually secured. With this division, we are now finally left with a few centimeters of liver tissue in the region of the hepatic vein, and we'll continue the dissection from outside and inside, isolating the hepatic vein, securing it, and then dividing the remaining liver substance. Proceeding in this way from both inside and outside the liver gives a very accurate idea of the location of the hepatic vein, which is here seen being clamped on the vena cava side. This vessel is always doubly clamped as it is very short, and if let loose, can give rise to torrential and sometimes uncontrollable hemorrhage. With the hepatic vein secured, the remaining liver is divided and the resected fragment removed. The inflow control is now removed so that we can see any bleeding from the cut surface of the liver. The hepatic vein is oversewn with a continuous suture of 4-O-proline to secure it completely. While oversewing the hepatic vein, it is important to space the sutures correctly so that no leakage of blood can occur between them. The closure has to be accurate and watertight. So that completes the suturing of the left hepatic vein lumen, and the ligatures are divided. The inflow occlusion is now removed and we can see a slight degree of oozing from the cut surface of the liver, which is controlled by diathermy, clipping, and later the application of a Surgicel sheet. It is of course important to leave the raw surface of the liver completely dry and carefully check for bile leaks, which must be sutured off to prevent later biliary peritonitis. Here the last few escaping red blood cells are coagulated, and finally Surgicel will be laid on top of the cut surface to provide the last degree of security. So that's the Surgicel going into place, and an intraperitoneal drain will now be put in to exteriorize any minor leaks that occur. The slings are removed from the inflow controls of the liver. A final check is made of the hepatic vein area to make absolutely sure that there is no leakage of blood. That is the intraperitoneal drain being led out through a separate stab incision lateral to the hepatectomy incision. It is placed away from the porta hepatis in the right Morrison's pouch, and we'll now be closing the wound in layers using various appropriate thicknesses of polygalactin sutures. The patient had an epidural analgesia catheter placed in at the start of the operation, which was used for administering epidural analgesia for 5 days postoperatively. This was extremely helpful in reducing the morbidity from this very large and obviously very painful incision. One of the nice things that we have noticed during this operation is the remarkable lack of intraperitoneal adhesions despite a major abdominal operation having been performed previously. Normally, in a large incision of this type, we would also infiltrate bupivacaine into the subcutaneous tissues for postoperative pain relief. However, this child has already had placement of an epidural catheter, which will be used for postoperative analgesia. So that completes the closure of the subcutaneous tissue layer, and skin sutures will now be inserted using 3x0 nylon. Post-operatively, the child was administered IV ceftriaxone, sulbactam, metronidazole, and amikacin for 5 days. Epidural analgesia was also continued for 5 days and provided tremendous relief from pain and morbidity. Oral intake was begun upon the return of bowel sounds, and the urethral catheter was removed after 72 hours. The child was discharged from hospital on the 7th post-operative day. Thank you for watching this video.